Next up, we have Brian Anderson, who's going to be talking about a really groundbreaking study that's happening here in San Francisco, the Psilocybin-assisted group therapy for demoralization in long-term HIV and AIDS survivors. Brian is a psychiatrist and postdoctoral fellow at UCSF and the San Francisco VA, where he is the study lead for the university's first clinical trial of psilocybin-assisted psychotherapy. Brian has also been a member of the Núcleo de Estudios Interdisciplinares sobre Psicoactivos since 2006, and currently is Associate Director of the Chacruna Institute for Psychedelic Plant Medicines. Over the past decade, he has conducted ethnographic research with ayahuasca religions, 12-step recovery groups, and other communities of substance users in North America, South America, and Europe. So come on up, Brian.
So, good afternoon. This is a real pleasure to be here and to be sharing some information about the study that is ongoing here in San Francisco. One thing that's really important about this study for me is that we really tried to base a lot of what we did with information from the community that we were working with, and that we really tried to emphasize community. We tried to really take serious the saying of drug set and setting, and we really looked at setting in a way that I hope makes sense and is comes across in the presentation, and I think was rather important for our participants. So to start, as Gregory said, this study is called Psilocybin-assisted group therapy for demoralization in older long-term HIV/AIDS survivors. We're going to break that down a little bit. But I just want to first say I don't have any financial conflicts of interest to disclose regarding this study or what I'll be presenting here. But as we know, psilocybin, not the mushrooms themselves, but psilocybin, the synthetic compound, that's what we used in the study. This is a Schedule I drug, and so it does not have any approved, FDA-approved medical uses in the country at this time. So we worked with older long-term HIV/AIDS survivors for this trial. What that means is these are individuals who were diagnosed with HIV or AIDS prior to the availability of life-sustaining treatments like combination antiretrovirals. People who were told, you're going to die, and they watched many people around them die from this disease. Many of them lost a lot of people in their community and ended up coming to us looking for help in part for dealing with that loss that they've been carrying now for many years. What's intriguing is that older in the HIV positive world is 50 and up, if you look at the medical literature, because people who have been living with HIV for years start to show signs of age, frailty, diseases and conditions you might only see in people in their 60s or 70s. They start to show that sooner. So we're working with a group of people who faced death, lived with a lot of death, and now are starting to show the signs of aging and premature aging earlier on. This graph comes from the San Francisco Department of Public Health, and it shows the number of people living in San Francisco who ever were diagnosed with AIDS. So you see that, and that's the orange line that sort of has grown over time, starting in the early 80s. The yellow line is the number of people diagnosed per year, and then blue is deaths from HIV/AIDS, and then the orange line shows that people who are diagnosed with AIDS have started to live and live near normal life spans. And we now have about 9,000 people who at some point were diagnosed with AIDS living in this city. San Francisco is one of the first cities in the country to have more than half of the people living with HIV be over the age of 50. This is a group of people who never thought they were going to live to be older, never thought they were going to see 50 years old. And so San Francisco, we started seeing that, and maybe in about 2015, we started seeing this in other parts of the country as well. But just by 2 years ago, 65% of people living with HIV were considered older here. And that is reflected in the movements in the community, in these different AIDS and HIV service organizations that started to talk about and wanting to address what does it mean to be older living with HIV? What does it mean to live to an age where no one thought we would get to be there? And what do we need as far as medical, social, and other sorts of supports to meet this community where they're at? This is why we have things like the Reunion Project, Let's Kick AIDS Survivor Syndrome, and the 50 Plus Network over at San Francisco AIDS Foundation. There's not a lot known medically, health-wise, about older people living with HIV, and in particular, long-term AIDS survivors. Again, older people living with HIV is anyone who's 50 and up. So that means someone could be 50, 55 years of age and be diagnosed with HIV. But long-term survivors, like we said, have been living with the virus for many years. But thankfully here in San Francisco, there's a number of healthcare providers and researchers trying to understand what are the needs of this population. This is just one study looking at people over the age of 50 with HIV who are seeking primary care, not specific mental health care, but seeking primary care in 2 clinics here in the city. And they did a survey of symptoms for depression, anxiety, PTSD. What you see here, over 50% of people met some sort of criteria for mild, moderate, or severe depression. Again, a lot of anxiety, a high rate of PTSD, and then importantly, a lot of loneliness and low social support. Zooming in a little bit on depression, by classic DSM diagnostic criteria, depression, it means that you have, for a prolonged period of time, low mood or lack of enjoyment and pleasure in your normal life, as well as a number of other symptoms like trouble with sleep, appetite, thoughts of death, and that this impairs your functioning. Now, if we only look for people who meet this classic definition of depression, we're going to miss people who still have symptoms related to this and other conditions that are seeking care, but might be told, listen, you don't have depression, you have something else. Go talk to someone else, maybe go talk to a counselor, but you don't have depression. I don't know what to do for you. And yet, when we look at the mental health needs of people, and this is specifically here in San Francisco, who are in this cohort, when you ask them, what do you need? What is important thing for your health? In one study, when given a list of conditions that patients said we want our providers to address more, it's depression. In another study where they looked at how frequent people have depression who are living with HIV and are above the age of 60, up to almost 40% of them met criteria for depression. Looking at people in that age group who didn't have HIV, it's 10 times less common. And then similar studies, again, here in San Francisco, showing high rates of depressive symptoms in this group. But my argument is that depression doesn't tell the whole story. I want to go back actually to the 1980s. This is a paper published in 1988 when they went and they interviewed men who had lost someone to AIDS in New York back in 1985. And they found a high prevalency of what they called demoralization. They characterized this as a syndrome of feeling stuck, feeling helpless, and feeling just like giving up. Demoralization is something that we study in mental health. What it means is it's a difficulty with coping with a situation in life that is felt as a sense of hopelessness, helplessness, or a loss of meaning and purpose. This is actually rather common in people who have a serious medical illness like HIV, cancer, some other form of life-threatening condition, and is very highly associated with suicide, actually more so than is major depression. And there aren't great therapies for it. Another condition that I think is really pertinent for this group of people we're working with is complicated grief. Now, grief is normal. Grief is healthy. When you lose someone dear to you and you mourn them for weeks, sometimes months, we consider that to be a normal human experience, and that can help sort of process, their loss. When that mourning and the sort of impact on your life goes on for maybe 12 months, maybe years, and you continue to be stuck in not being able to sort of in a healthy way, let this person move on. That's considered complicated grief, and some would argue that's a condition that we should treat in mental health. What's important is that this is actually pretty common, especially when people have a traumatic loss, like a lover who dies suddenly and you didn't have a chance to say goodbye. It's also associated with suicidal thinking, and there are some treatments for this, but it's not very widely recognized and it's not always treated. So that's the build-up to why we did the study that we did here in San Francisco at UCSF. Now, psilocybin, many of you know about this. Again, we used a pharmaceutical version of pure synthetic psilocybin, so in a capsule, not the mushroom. And what's interesting about this compound compared to other tools that we have in mental health today, this is a serotonin agonist, works different than serotonin reuptake inhibitors or SSRIs. We give a moderate to high dose of this medication. The effect lasts about 5 to 6 hours, and it has some, as I think people here know, some very strong effects on people's thinking, their feeling. And for people who have never taken this before, when we're enrolling them in the studies, sometimes I think the best thing I can say is this is like having a very vivid, lucid dream with your eyes open for hours. When psilocybin is administered in a medical setting, this is a photo from the Johns Hopkins team, we try to provide a nice, supportive, warm background. There's often 2 therapists. This is the standard male-female dyad. We did not use that in the study, and I'll go into that in a little bit. And mostly the participants are told to lie down, close your eyes, go internal, listen to the music, reach out if you want some, to engage briefly, if you need some reassurance. But mostly the therapists try to stay out of the way of the experience that the medication engenders. What we did in the study is we did an open label trial, meaning we didn't say, okay, you're going to get the medication or you're going to get a placebo. Everyone got the medicine, and they knew that when they enrolled in the study. We did this as a safety and feasibility study. We weren't trying to show that this helps. We wanted to show that this can be safe to do when we change things up a little bit from what's been done before. We worked with long-term HIV/AIDS survivors. This is a new group of people to work with. Quite a few of them either had cancer or were cancer survivors, as we see commonly in people who have been living with HIV for many years. So in that way, it does relate to the other studies that were done at NYU, Johns Hopkins, and UCLA with psilocybin. And we worked with group therapy. That hasn't been done in any prior clinical trials that have happened over the last 20 years. There's many examples of using psychedelics in group therapies from the 1950s, 60s, 70s, but it hasn't been studied in the modern clinical trials, and so we wanted to go back to that. And the primary indication that we looked at was demoralization. Again, we worked with long-term AIDS survivors. I'm showing you data from groups that we selected only gay-identified men. The study is ongoing and does include women as well, but this is data just from working with men so far. And we made that as a selection criteria for the study because we wanted to create safe spaces with people with some similar life experiences and give them a place to sort of open up, share, and connect. And we can discuss that. That can be part of the questions later. And we definitely got feedback from the community that was well received and helpful, that we should have included women from the get-go in these first groups. But I can also say that when we talked to the men who we did include in the groups, a lot of them were really grateful that we had a space of people very similar to them, and they said they wouldn't have felt safe with straight men, women, etc. So that's what I'm showing you so far. And we included people only who had a significant amount of demoralization that they reported in their life. As with other studies with psilocybin, MDMA, LSD, we have to exclude a lot of people who were interested in the study and looking to access a experimental treatment like this. So there's many different types of psychiatric medications that people cannot be taking while they're in the trial. If people have such severe mental health conditions at the time, like they're actively suicidal, or they might need to be hospitalized, they can't obviously be in outpatient trial like this. And we have some serious medical things that we looked for. One of the big things is heart health. So cardiac disease can be a real contraindication in doing high-dose psilocybin therapy. So we looked at that pretty carefully. Stepping back and talking about how we even put this together, community feedback was great. It was super helpful, and we went out and sought it. So one of the things that we did early on is that we worked with a number of HIV/AIDS service agencies here in San Francisco and other parts of the Bay, and we were part of a town hall where different groups that were providing services or conducting research on the mental health needs of older people living with HIV got together. We presented some ideas for the study. We got a lot of feedback, and we collaborated with long-term survivors who are consultants with us from the beginning. We also presented some of our methods and initial findings to the AIDS clinical trials group. They have a community advisory board made up of people who are researchers, community members of different sorts, long-term survivors themselves. They gave us feedback, and then we collaborated and spent time over at the AIDS Foundation, where there is this active social network supporting people who are older living with HIV, and that went into the design. Informed consent. So this is tricky, right? How are you going to inform people about these very unusual experiences that they can have when they've maybe never taken a psychedelic before, or even people who've taken psychedelics many times, as we'll see from some of the data in our study? This was hard, and so we also had to be mindful that we're working with an older group of people who have a lot of medical conditions sort of at baseline, and so we sort of broke it down: what's likely, what's less likely, what's rare but serious, and these were the things that we were considering, and people had to agree to take on this risk in order to be in the study. You know, I think as people here know, chances of having anxiety, paranoia, fast heart rate, your blood pressure can go up. These things are pretty common. We had to tell people that, you know, you might lose control of your urine and stool. That did happen in the study. Some people can get nauseous and throw up. And then there were some, you know, severe risks that people took on that did not happen. But we have to tell people that we might make you rather psychotic. You might go to a very dark place. But we're going to provide you with a lot of support to try to prevent that. And so the participants in the study were willing to take on those risks. This is the layout of what participants actually went through. So the whole participation in the study took about 2 months. That includes coming in and being assessed for whether or not someone's eligible for the study. Once they were eligible, and then we were able to select enough people to form a group, so 6 participants. Each participant came in and had an individual session with the 2 group therapists. I just want to give a shout out to Chris Stouffer, who's here, who was one of our therapists, along with Alicia Danforth and Rob Daroff, who were instrumental in putting this together. After meeting the group therapists and having sort of their an individual therapy session to kind of get used to the working with these clinicians and hear a little bit more about what's going to happen, we jumped in. We had the first group therapy session. We had the 6 members of the group meeting each other all at the same time with the 2 group therapists with them in the room. And then they met 4 times over a period of 2 weeks. So we did Monday and Wednesday evenings. Then we broke up the group. And then we had the medication administration days. This was not done in a group. All right, so just to be really clear, participants would come in and take the medication with 2 clinicians in a room, but not have the other group members there. Luckily, UCSF has been really supportive of this work, and we were able to get 2 medication treatment rooms, so we could treat 2 people in a day. And this is one of the best parts of the study. We would bring those 2 participants together afterwards, after they had sort of come back to themselves, and they could debrief together with someone who had just gone through something maybe similar to what they did, maybe totally different, but they knew each other, had already built some trust and some bonding, and they were able to talk, to see each other, maybe hold hands, but be with someone else like them who is going through a similar process. After all 6 participants had gone through this week of treatment So the first 2 people went on Monday, the next 2 on Wednesday, the next 2 on Friday. We brought them back together, and then they met twice a week for the next 3 weeks. And as someone who is a psychiatrist, someone who does see patients, that was an amazing thing to see. 6 people who just went through sometimes a blissful, sometimes a harrowing experience, come back and sharing and connecting and opening up to each other in a way that just qualitatively I thought was very different from how the group was operating before they had the medication treatment. The study sort of end point, meaning sort of when we looked at our before and after measures, was at the end of the 6th group session after the medication, and then we did follow them for 3 months to see how they were doing after this. And just a note, this is 19 hours of psychotherapy, right? Normally, if you get referred to a course of CBT or sort of standard therapy, that might be 12 hours, 16 hours if it's something that's manualized therapy that insurance pays for. So we're doing that plus giving them psilocybin. So in looking at the outcomes, you have to compare this to what people might have outside of a setting like this. The therapy is important. You know, we would tell the participants this is maybe half about the drug, half about being in group and doing your work in group therapy. We really tried to emphasize that point. We adapted a brief psychotherapy that had been developed for metastatic patients with metastatic breast cancer. That in the 1970s and 80s, when this first came out, you didn't talk about cancer. You didn't go to these shameful places. You didn't talk about the big C, because what if the neighbors find out? You know, what if Aunt Jenny hears that, you know, you have cancer? And there was a lot of stigma, internal stigma about having this disease. And this group therapy came out at a time that said, no, we're going to talk about it. We're going to express our feelings. We're going to be with other people who are suffering in this way, and we're going to connect and support each other. This has been adapted for people living with HIV AIDS previously, and we thought that this would be a nice model of group therapy that has some evidence for how it works, that has a manual to support how to train people to do it, but was still flexible enough that we could combine this with a psychedelic, and it would be able to accommodate, you know, maybe on session 6 of this group therapy model, we're not going to do it all like things were planned. Maybe we don't have time, like in some of these therapies that are set up for palliative care patients, that you do this on this day, you do this on that day. We have to be open to what psilocybin is going to bring and where the group is going to go. And this therapy was rather flexible and was helpful for that. Now, a little bit about the findings from the study. So who was in the study in the first place? Average age was about 60. The average age of HIV diagnosis was 1988. And so the spread was from 1981, a participant who told us that they were diagnosed with GRID, right, before we called it HIV, before we called it AIDS, to 1996. Only 8 of them remembered what their CD4 count was at its lowest, which is something that a lot of survivors will tell you. Many of them will say, you know, this was the date, this is who read me the test, this is the number. But so 91 was the sort of average lowest. And here's something that really stands out to me is we asked them, how many people in your life who are close to you have died over your lifetime? And what's helpful is to look at the range. Our participants' smallest number, 2. That person said, I didn't let anyone close to me. I saw what was happening. I didn't want anyone to get close and have to lose them. Another participant said, probably about 100. I was a nurse working in AIDS units. And many of my close friends were my patients, and I lost a lot of people. And so there was a whole range there. We also asked them about prior psychedelic use, and there was quite a spread. About half of them had used psychedelics less than 10 times in their life. The other half, some of them had used many times. But the majority of them hadn't used psychedelics for many years, sometimes 20 years. But there was one participant who tried mushrooms just a few months before the study for the first time in his life because he thought it might be helpful. And it helped him some, but not enough, and he wanted to come back and try more. And that was not an exclusion criteria for the study, and so we included him. So we had one participant who identified as Black or African American, 3 of multiple races, and 14 who identified as white, and 1 identified as Latino. And this is sort of the breakdown of the study. We screened 91 people over the phone. About half of them were not eligible for the study just over the phone screen. 37 came in person. 30 ended up meeting criteria to be in the study in the first place. 37 could come in for the screen. 30 came in. Only 18 were eligible. Of those 18, all of them enrolled, and actually all of them finished the study. So like Chris's study with oxytocin, this is unusual. We did a group therapy study with people with sometimes some very complex medical and psychiatric needs, and they attended 95% of the therapy sessions. This is a very motivated group, and we would be more than lucky if we were able to replicate this in the future. We did a psychiatric assessment with participants when they started the study. This is called the SCID. What this is it's a structured interview that a clinician does with someone to try to figure out what their diagnosis is according to DSM criteria. And again, to be in the study, you didn't have to have depression or anxiety or PTSD. You just had to be highly demoralized. So we had a spread of what these DSM diagnoses were. GAD, which is generalized anxiety disorder, MDD, major depressive disorder, panic disorder. We had 3 participants who met criteria for borderline personality disorder. And then 3 of our participants, according to this one scale called the PCL5, might meet criteria for PTSD, but we did not do the gold standard assessment to see if they had that condition. What's interesting, though, is many of our participants said that they had trauma, right? And so this is something important, that people can have trauma, be affected by trauma, might not meet PTSD criteria. For the last month, I had all these symptoms, but they can still carry trauma symptoms and be affected by things from the past. And that's a lot of what we were working with. Again, being a safety and feasibility study, we looked at safety really closely. We used some standardized tools to assess that. And then we had to, as with any sort of clinical trial that uses a Schedule I drug, we had to be engaged with our data safety monitor, certainly the local IRB, our ethics committee. In California, the California Department of Justice has their own regulatory body called the Research Advisory Panel that oversees any study with a Schedule I drug. So we had to work with them, FDA, and certainly DEA to do this work. What's important in clinical trials is looking at serious adverse events. This means, did someone have to get hospitalized? Did someone go to the emergency room? Did someone, almost die or have some sort of, life-threatening situation? We had a few of those during and after the study, but none of them were related to the drug itself. And then we looked at suicidality, so thoughts of wanting to die or harm oneself throughout the study, and we did not see that go up at all from psilocybin. And actually the suicidality, even just thinking about wanting to die, was pretty low, so we didn't see any improvement because there wasn't that much active suicidal thinking to begin with. As you might expect, the health issues that came up on the medication treatment day itself, pretty standard. Anxiety, paranoia. We saw a fair bit of high blood pressure. We saw more than most sites have seen, and I think in part that was because our population had a lot of trauma, anxiety, as well as they were just older. And other things like nausea, restlessness, unsteady gait. These are all sort of these adverse events that happen to more than one person. But like I said, there were other things like loss of control of the bladder, peeing on oneself, that happened as well during the study. And then the common adverse events after, meaning from the time that the drug was given, the next day until the end of the study, headache, fatigue, insomnia. Again, these have all been reported in other trials as well. This is a measure that I think is rather important, and this is the one clinical measure I'm going to show today as far as the actual outcomes on mental health in the study. We use this tool called the Inventory of Complicated Grief. And what this does is assesses that idea of grief that's not healthy, that sticks around for longer than we think is normal. And it specifically asks you to think about someone in your life that was close to you who has died and whose loss has really affected you emotionally. And then it goes through and asks you things like, right now, do you think about this person so much that it's hard to do things normally? Do you feel like you cannot accept the death of the person who died? Can you not help feeling angry about their death? And so they answered this at a number of points throughout the study. And then what the results looked like for this measure are actually pretty similar to some of the other measures, depression, demoralization, et cetera. But what you see is that, and for some reason over the phone, this measure was quite a bit higher than in person. So maybe that was a fluke, but at enrollment, that's the first day that we met these participants in person. They came in, they filled out this form. Week 0, that's when they come in, they meet their group therapist, and they haven't met the other group members yet. And week 2 is after they've completed 4 group therapy sessions. Then again, remember, there's a pause of a week where they don't have the group session. Each person comes in and has their psilocybin medication treatment, and then they come back. So week 4 or 5 means this is about a week or so since anyone has had the medication and they're just had their first group session back. We measure it again about a week later, and then a little bit after that, so about 3 weeks since the medication. And you see that this self-report of complicated grief stays lower for quite a bit of time after the medication. We can look at this statistically, and we can see that there is a statistically significant change before to after psilocybin. So just to summarize what we saw, in this population of long-term HIV/AIDS survivors, there's a lot of mental health needs that are not being met in the community. And the community is rightfully so being expressing that depression, trauma, grief, these conditions, participants are going to their healthcare providers and looking for help for it. But many of the times they're told, listen, you don't quite have normal depression, you don't quite have normal PTSD, we're not sure what to do for you. These were a lot of the people who came to our study looking for help, trying to identify what they're suffering from. There's a lot of loneliness and isolation in the community right now, here in San Francisco. And this, I think, is an important clinical thing for us to address. Right, the clinicians in the room, we should be talking to our patients about isolation. We should be talking to them about loneliness, especially in populations that had to leave the family of origin, go find a chosen family, had it taken away by a plague that hit the city many years ago, and felt like they never really found community and support after that, or at least it's been a struggle to do so. And we can try the available treatments like psychotherapy, SSRIs, things like that, but many of our patients are saying it's not cutting it. This is why psilocybin, group therapy, this is why we did this study. I'm really happy to show that this is feasible to combine psychedelic therapy with the group model. I hope that more institutions look at that and think about what might be beneficial of doing this in groups. I can tell you a lot of the participants, whether or not they had full trust in the clinicians, whether or not they had full trust in the medical establishment, whether or not they felt like in a short period of time, they could totally bond with the people in the study, and many of them were really grateful and really wanted to work with us. They really bonded with each other. And a lot of them, I think, held on to getting out of this experience, getting back and processing with that group. Some of them said, you guys were there with me, and that's what made me be able to do this. And so just thinking qualitatively about what the participants were saying to us and to each other because they had this group support, I think is fundamental. I think we know that from community settings, but how to translate that into possible medical use, we should stop and think more about. And so given that, I want to say thank you to a very large team that it took to put this together. Starting at the top, 3 of our long-term survivor consultants, who we could not have done this without them, and a lot of their community support that they were able to draw up for this. There's a number of co-investigators, and again, the clinicians who made this possible. And this being psychedelic therapy research, this being a clinical trial that did not get funded by the NIH, did not get funded by federal institutions. We funded this with donations and a lot of people volunteering their time. All of our clinicians, except for the group therapists who had to show up regularly, all of our clinicians volunteered their time. And we're really happy to do this for the community, to be of service, and to have this privilege to sit with our participants who are brave enough to come and do this work with us. And so, thank you to the clinicians, and thank you to all the participants who showed up and did their work. Moving forward, we will be opening up the study again and working with at least one group of women this fall, and hopefully another one in the spring. We did get approval from the IRB and the FDA for the protocol modifications to have a group for women. We're still waiting for final approval from the California Department of Justice. I hope that comes through soon, but we hope to serve a group of female participants in the fall. Thank you.
Thanks for the talk. That was great. You mentioned towards the end, and I think I came in late, so I don't know if you mentioned this earlier, that a lot of the members or a lot of the study participants had used SSRIs as first-line therapy. Was current use of SSRIs an exclusion criteria for the study? And if not, did you see any interactions between that and the psilocybin?
No, sorry. So that line was about what is currently available clinical treatment. First line therapy, meaning like if you go to your healthcare provider, they're going to offer you this, right? But no, people who take SSRIs, the FDA pretty much has said that, you can't be in these clinical studies if you're taking medicines like that. And there's a number of reasons why. Yeah.
Hi, my name is Courtney. Thank you for your presentation. The question I have is for the one that you're recruiting for. Mm-hmm. What ways are you going to try and ensure that Black women and trans women of color are really represented in this study? Since we are, well, not trans, I'm not trans, I'm cis, but as Black women, and knowing that trans women are disproportionately affected by HIV and AIDS.
Yeah, thank you. What I've been really happy about with the study is that we started going to the community and trying to get involvement on study design, what even the questions were, but also definitely for recruiting and making people aware that this is something that we're doing here. At the same time, we also tried to sort of do things kind of quietly, like we weren't out in the news saying we're doing this study because we wanted to just have things happen smoothly and not draw too much attention, but we did reach out through the community. And so as we start to build up and actively recruit, we're going to be doing the same thing, going to different community organizations, working with stakeholders who have worked with different populations, instead of trying to meet the community like geographically where they're at. But the issue of when there's even treatments that people have access to, but all the different reasons why they're not accessing care for HIV mental health. This is something that we will have to contend with, just as all the care providers in this area and other parts of the country have to contend with these serious discrepancies. Sorry, not discrepancies, but inequalities. In particular, people of color and trans women, trans men. So thank you.
Thank you so much for your talk. I'm Joey. I'm wondering if there's been any consideration of doing this kind of work with people who were caregivers during the plague, who cared for hundreds of people and went through the whole thing, but never actually seroconverted themselves.
Yeah. So thank you. So many of our participants, right, were caregivers as well. Absolutely. And that's a lot of what they carried, is that they sat for many people who passed. But there are long-term survivors, exactly, who did not seroconvert, who were caregivers and carry a lot of that burden as well. It's not to sort of disqualify or discredit that work, but part of at least my work here is I work with people with medical illnesses who also have mental health challenges, and that's something I try to bring focus to, and that's how we crafted this. But there definitely should be, and not just in HIV, there definitely should be caregiver studies for many types of conditions. This perfectly would qualify, but there's a lot of talk, but I haven't seen the study yet, of providing psychedelic therapy to people who've cared for those who have died of cancer, terminal neurologic conditions, but certainly HIV/AIDS as well. Thank you.
Hi, my name's Laura, and I was slightly late from lunch, so I don't know if you talked about this yet, but I'm, okay, so last year at Horizons, there was a lecture or a presentation about looking at psilocybin with people who have been addicted to crack cocaine. And one of the things that I found the most disturbing about the presentation is that they did use a controlled group that was just getting placebo, and they never ever gave them the psilocybin. Mm-hmm. And just because there's so much, what's the word? Just like there's so much in the medical industry where people are being oppressed or used for testing that then is like just really not in their favor. And I found that really disturbing. And I really appreciate that there's no placebo in this, and it's open label, which I know is complicated in terms of research. But I wonder about your thoughts on that, like research studies that use placebo and don't provide people with the thing that everyone else, that half the group is getting when they've gone through a whole study, and they are like a very, very impacted population that does need healing.
Yeah. So thank you for that question. Mental health has not had to struggle with that question quite like other fields like cancer and HIV, where if you have a treatment that you have some good reason to believe will be helpful for people who might enroll in the study, can you not give them that treatment, right? Is it, in the case of a life-sustaining treatment, again, like HIV trials, to do placebos, that was a big controversy back in the day, and the field has kind of come to some agreement about how they're going to do that type of work. In mental health, if something is a serious condition, like an addiction, you'd have to weigh whether or not, is it a life-threatening condition, and do we have things that we know will make that person's care better? My guess is that for something like an addiction that has a serious impact on people, if we have enough evidence that psilocybin will make that better, at some point, the IRB, the FDA will say, no, we don't want these double-blind trials because we want you to be able to offer that treatment. We also need to get the field to a point where the FDA looks at it and says, we've seen that this is so promising, we don't want you to deny it from people who might benefit, right? So it's that dance, and I think some of these early studies have to, work within blinding, because that's super important in mental health, because we know just giving people placebos and being in a study actually makes them way better a lot of the time too. And like I said, 19 hours of free psychotherapy, I would love to get a lot of my patients 19 hours of free psychotherapy. So I think there are some benefits to being in these studies, even when there's a placebo, but we have to design trials in a way that's ethical and mindful of the needs of the people who are volunteering their time and their health to be part of this science.
Hi, my name is Karis. Thank you for your research. My question is actually back to what that person over there was talking about. So the disproportionality between how many people who are Black are suffering with AIDS and HIV, and then the numbers in your, research of like how many, Black people were included. Mm-hmm. And I'm wondering if you have like consulted with, or if you have Black or people of color on your research team to talk about like maybe like the historical violence against Black people in like the medical industry specifically, or other barriers that you might face in recruitment, or if you've started that conversation to, get a better representation of who really needs this help.
Yeah. So, I mean, one important part of this study that determined the outcomes, I think, of people who knew about the study, were curious about enrolling, and actually made it into the study is geography, the demographics of older long-term survivors, specifically in San Francisco. This turned out very different than I think if we had been in Oakland, right? Or in other cities in this country. And so geography, we know, played a role in this, including just the organizations that we went to, where we went out to the Reunion Project, the San Francisco AIDS Foundation, where there is diversity of people seeking those services. But definitely being here in San Francisco, I think this turned out very different than if we were in Los Angeles or other, or for instance, the cocaine study in Alabama, the demographics would have been very different if this were done at Birmingham, where Peter Hendricks is doing his work.
Part of why it was so concerning, because almost everyone in that set was Black, and they were not like receiving the care that. Anyways, I appreciate how you did your study, but that's
So I'll just say, yeah, we've talked. This is San Francisco, though, where I would hope that at UCSF, we spend a lot of time thinking about structural issues that do impact health. And this is where a lot of the HIV work came out, where we try to recognize that this is not just about drugs. This is not just about medical intervention, but this is about social settings that have big impacts on how people's health and well-being is at the end of the day, beyond just one doctor and one medical treatment. But at the same time, we had a study of 18 people. Nothing's generalizable about a study of 18 people. And when these are bigger studies, there will need to be more diversity, certainly, to have this be meaningful for the whole country and not just some people in this country.
Okay. Thank you for your work. I would love to speak with you further about this. My question is about the language that you've used to get people involved. Just thinking about how this is a population that has had a lot of difficulty with the medical system. Mm-hmm. And how you make it seem inviting to people who have been demoralized by psychiatrists and therapists and mm-hmm. other doctors. How do you make it inviting and welcoming so that people are wanting to be involved?
Yeah. So we enrolled in this study only people who wanted to be in a study, right? If people didn't want to be in a hospital setting, working with health professionals, having experiences like this, they wouldn't have come to us. A number of the participants also said, I wish we were in a yurt out in the woods. Like, why do we have to be here in this hospital? Why do we have to have a blood pressure machine? Why do we have to do these things? Some participants also said, I'm really glad to be here. Some participants said, I used to use all sorts of substances, and now that I'm older, I have these health conditions I'm dealing with. I feel a lot of comfort being here. We had one participant who was in recovery for, I think, over maybe 20 years. And his friends were concerned that he was looking for something to help him deal with trauma. He was considering going and getting psychedelic therapy in the community. And they thought he was at risk of relapsing. This was his social support. And he ended up saying, no, I'm going to go do this with some doctors. His social support ended up getting behind it. And he was relieved and didn't feel like he was at risk of losing his sobriety, which for him was important. because he was doing this in this setting. But that's not for everyone. And so we worked with people, again, who had some significant concerns about just the medical establishment, if you want to call it that, or physicians, because of things that the FDA, the NIH, and healthcare providers did back in the day in the epidemic when it wasn't recognized, treatments were not being provided like the way that they should have been. And these were the activists who were storming the FDA and marching on Washington in ACT UP, who then came and now are coming to us to try to be in this study. A lot of them were part of that original movement. And so some people just wouldn't want to work with us, but we basically, tried to be as open to their experience and their needs as we could. And those are the people who chose to, try and trust us and work with us. Yeah.
Thank you, Brian.